Hi, good afternoon. My name is Dr. Mascotti. I'm the Chief Medical Officer here at Naples Community Hospital, and with me today I have Dr. Sharma to talk with us about atrial fibrillation. So thank you so much for joining us. This is our second of the series in our cardiac community Zoom. Our first talk was on COVID heart disease and COVID-19 and heart disease, and that went over quite well with the community. So a second of the series is today we'll be talking about atrial fibrillations, and then we'll talk a little bit at the end of the other two we're planning. So I'd like to welcome Dr. Sharma today for joining us this afternoon to talk about atrial fibrillation. He received his MD from New Delhi and then did his residency and a fellowship at East Tennessee State University, and then also at Cedars-Sinai Medical Center. So he specializes in cardiovascular disease as well as clinical cardiac electrophysiology. So we'll be learning about why that's important for treatment of AFib. So thank you for joining us today and welcome. And we'd love to hear a little bit more about atrial fibrillation.
Well, thank you, Dr. Mascotti. Actually, I have a small presentation. So to better understand atrial fibrillation, it's the most common arrhythmia, and I'll start with two small videos so that everybody can have a brief overview, and then I'll start talking about more as we go through the slides. So let's play this.
Atrial fibrillation, also known as AFib, is the most common type of cardiac arrhythmia, affecting over 5.5 million people in the US. AFib is an irregular and often fast heartbeat that results in uncoordinated contraction of the top two chambers of the heart. AFib can produce symptoms such as palpitations, fatigue, shortness of breath, or difficulty exercising. However, 15 to 30% of people with AFib may suffer from silent AFib and may not have any symptoms at all. A person's chances of developing AFib increases with age. In fact, 1 in 4 adults 40 years and older are at risk for AFib. AFib is a progressive disease, with 1 in 5 patients progressing from occasional, also known as paroxysmal AFib, to persistent AFib in 1 year. If left untreated, AFib creates severe risks for patients by increasing their chances of life-altering or potentially deadly events, including a 5 times increase in heart failure, 5 times increase in stroke, 2 times increase in cardiovascular mortality. The good news is that AFib is treatable. However, awareness of treatment options is insufficient, leaving patients often underdiagnosed or referred to a specialist too late. Drug therapy can be an effective treatment for some AFib patients. However, 50% of AFib patients still suffer from symptoms even while being treated with drug therapy. Catheter ablation technology for AFib has evolved and improved over the last 20 years. Catheter ablation can provide incredible success in patients, with some studies demonstrating a success rate of up to 88% at 12 months. The best way to fight this disease and improve quality of life is with early diagnosis and treatment. Visit our Get Smart About AFib Facebook page to join our community of over 100,000 patients, or to find an electrophysiologist.
And so that was actually what we're going to talk about in this presentation. And I'm just going to play this one more animation, which I thought was very nice to understand what atrial fibrillation is.
The heart's electrical system directs our heartbeat so that the upper and lower chambers beat in sync with one another in a strong, steady rhythm. During AFib, an irregularity in the heart's electrical system prevents it from beating normally, and instead, the upper chambers quiver, affecting blood flow and increasing the risk for stroke.
All right, so now I'm going to talk more about atrial fibrillation. So you saw in those animations, the atrial fibrillation. So let's just look at the picture of the heart. So this is, if you slice the heart open, there are 2 upper chambers and 2 lower chambers in the heart. So normally the heart rhythm starts from a small tissue in the right upper chamber. We call it sinus node. It's like a natural pacemaker. The current starts from this region, and then it goes like a light bulb to the rest of the heart. And then once the upper chambers beat, then the current flows through this specialized connective tissue and gets to the lower chamber of the heart, and the lower chambers beat. But what happens in atrial fibrillation is that the current instead coming from here is all over the place. Every cell is beating on its own. And what that leads to is there's so much current that the lower chamber starts beating fast and irregular. So that's one problem. The second problem is when the upper chamber is not beating, it's just quivering, the blood flow is very sluggish in the upper chambers. And especially in these area pouches in the heart. So this is called an appendage. It's like an appendix in the stomach, in the belly. It doesn't do any good, it just causes problems. So it can form clots here, and these clots can travel down and potentially go to the brain and give stroke. So that's actually the biggest fear of atrial fibrillation, because as in the animation you saw that some of the AFib can be asymptomatic. So the first symptom can be stroke. So this is how the heart looks, that left upper chamber looks like if you see from behind. And just to also understand why some patients develop AFib is it will be to understand that the heart, the left upper chamber, has these 4 veins. These veins bring the blood from the lungs into the heart. But you can see this heart tissue kind of encroaches into these veins, okay? And so this tissue is almost like in an area where it's not wanted. The vein is not part of the heart, but there's a tissue going into the heart. So it becomes unstable, and it acts as trigger to put the rest of the heart into AFib. So the most common area in the heart where the AFib comes from are these 4 veins, like the horns, coming from the left upper chamber. Let's see if I can move the slide forward. So there are 2 kinds of AFib, 2 main kinds. One is occasional, we call it paroxysmal, in which somebody will go into AFib and then go back into normal rhythm, and they go back and forth. So when they go into AFib, they have the symptoms, and then they go back to normal rhythm. And slowly and gradually, this disease progresses, and then it becomes persistent, which means you're in AFib all the time. And as our population is living longer, the prevalence of AFib is increasing, and it's expected that around 2050, at least, we may have millions of patients with atrial fibrillation. So it's becoming a very prevalent problem, very common arrhythmia. So, and it has a lot of implications to our health of the country. So there's some risk factors which put somebody on higher risk of atrial fibrillation. And the most common reason, which is very applicable to our town, is age. So the good thing is we are living longer because of advancement in medicine. Because we are living longer, so we're seeing more arrhythmias. As we get older, our upper chamber of the heart, they tend to get a little bit more unstable. So age is one of the common risk factors for atrial fibrillation. And then if somebody has a heart disease, such as they have stents in the heart, they have a heart failure, they will also have higher risk. And high blood pressure is easily treatable risk factor, and that's one of the common reasons somebody can develop AFib. And problems like thyroid, sleep apnea, diabetes, kidney problems, lung problems, they all can stimulate the heart and put somebody into atrial fibrillation. Other which easily addressed common risk would be drinking alcohol. If somebody drinks heavy alcohol, they put themselves on high risk for atrial fibrillation. And so it goes with obesity, and there is some genetic component to atrial fibrillation. It runs in some families, and there's some more research going on to identify the genes which are leading to atrial fibrillation. Sorry, my mouse is not so responsive here. Okay, could you? Okay, so this was a study from Australia in which they compared the groups. This was actually after catheter ablation, and in one arm, they did all the risk factor modification, which was control their blood pressure very well, make the patients lose weight. If they have sleep apnea, have them wear a CPAP machine. And you can see that the patients who actually did follow the lifestyle modification, their outcomes were far different than patients who did not. So addressing these risk factors is very important in managing atrial fibrillation. I think I got it. So what somebody would feel if somebody gets atrial fibrillation. So most common symptoms are palpitations, shortness of breath. They can have chest pain if the heart's beating very fast. And actually fatigue and weakness is a vague symptom, is a very common symptom. Like somebody goes in AFib, they say, I cannot tell I'm in AFib, but I just can't do anything. So that's a symptom. So the fatigue is a very common symptom and should not be ignored. So if somebody has atrial fibrillation, their risk for heart failure goes very high, up to 5 times, because heart does not like to be out of rhythm. It can go very fast and out of sync, which can lead to heart failure. And as I explained before, if upper chamber of the heart is not beating, then the risk of stroke, it goes much higher because clot starts forming. Now, it also leads to higher, shorter life expectancy and higher mortality. And we believe that small strokes can lead to, someone increased risk of vascular dementia, which is they can start having cognitive decline. So in the last few decades, because of the treatments available for atrial fibrillation, we have made some strides. So this is data from Framingham study, and you can see that this is in 1970s to 80s. We were actually, the patients with atrial fibrillation, they were not doing well compared to normal population. They were having a lot more deaths, a lot more strokes. And then decade following, the gap decreased. And now this is from 2001, 2015. It is a significant improvement compared to what we started with, but still patients with atrial fibrillation, they have 2 years less of life. And it doesn't mean that atrial fibrillation causes somebody to die early. It could be because atrial fibrillation is associated with risk factors, which we discussed earlier, like heart failure, older age, and high blood pressure. So that could be the reason the patients with AFib, they tend to have 2 years less life expectancy. Now, how do you manage atrial fibrillation? So the two important aspects of it. One is managing the rhythm. So historically, somebody's in atrial fibrillation, a lot of times we used to give them medications to slow their heart down. So heart's not beating very fast, because if heart beats very fast, it increases the risk of heart failure. Your heart can be exercising nonstop. It has to, most of the people after 15, 20 minutes of exercise, they slow down. But if the heart keeps beating nonstop for days and weeks, then it's gonna start failing. So the first line treatment used to be that we just give them medication to slow their heart down, and patients become less symptomatic, and go from there. But lately, it has been, we are more inclined to put patients back in normal rhythm. Because the most common reason we were doing that is because patients develop symptoms. So if you put them back in normal rhythm, they feel better. So heart rate control is better. So they have less chance of heart failure. They're less chance of getting into the hospital. So, but a few weeks ago, we had a big study come out and published in New England Journal of Medicine. So this is the most reputable journal in medicine. It actually it showed an evidence that if we control somebody has atrial fibrillation very early on, so let's say somebody develops AFib, and within a month, we bring them back to normal rhythm with medications or ablation, they'll live longer, they have less strokes. So this was a remarkable, groundbreaking study. And I think this timing of this presentation actually is very good, because this study came out just a few weeks ago. So this again highlights it's very important for the patients in which we can successfully put them in normal rhythm. We actually make a big difference in their life, because they can live longer, they have less risk of stroke. So this is what the study showed, that if usual care in which we just give medications to slow the heart down, those patients had more strokes and deaths compared to patients who we were able to successfully, or at least we tried to put them in normal rhythm. Now, how do we get patients back in normal rhythm? There are two ways. One is, as I said, medications and ablation. So the medications, the most commonly used medication in elderly is amiodarone. And as you can see, as the time goes by, the efficacy of amiodarone goes down. And the other big problem with amiodarone is that it has a lot of side effects. It can damage eyes, thyroid, lungs, nerves. So if somebody takes it for many years, it's definitely going to damage, or I won't say definitely, but there's a very high risk of damaging an organ. So before, I would say a few years ago, we used to believe that somebody above 80 will just put them on amiodarone because we don't expect them to, outlast the side effects of the medication. But now people are living longer. I mean, there are some patients of mine who are 87, 88 year old, but they have a very good lifestyle. They go out in sun. They don't want to take amiodarone because they're gonna get sunburns, or they play tennis. So there's has been some change the way we practice medicine. This medication, because of their side effects, so we started doing like non-medication treatment, which was the ablation. So what ablation is, so this is again image of the left upper chamber, because that's where most of the AFib comes from. And being more precise, it comes from the veins in the left upper chamber. So what we do in ablation is we isolate these veins by creating a small scar tissue around them. So this is what I did in the morning before coming to this presentation, is with a catheter, we kind of give we cauterize this area one by one, or we can sometimes use something called freezing as well, a balloon catheter, and we create this scar tissue around the veins. So when we create the scar tissue, then the unstable tissue, which is in the veins, is not able to trigger AFib. And this strategy is very successful in patients who go in and out of AFib, or patients who are early in atrial fibrillation. So that's why the study also showed if we catch AFib early on and treat early on, our outcomes are really good. And sometimes when patients later in AFib, then we have a little bit more ablation. But the mainstay of treatment is to isolate these veins.
So Dr. Sharma, you're basically saying that electrocauterized tissue creates a barrier, so that disorganized tissue can't spread to the rest of the atrium. Is that correct?
Exactly.
Okay.
That's what it is. It's create a barrier, a fence, and we isolate these veins from the rest of the heart. Electrically, the blood flow can still continue, but electrically it becomes isolated. So actually, I have one of the images to show how the ablation is performed in the lab. So this is actually image of one of my patients I'm doing ablation on. So this is how it looks like. We have this mapping system, a 3D mapping system, which creates almost like a CAT scan image of the upper chamber of the heart. And this is the catheter, in which we're doing that, the lesion sets. And there are some other modalities and technologies we have to precisely ablate the tissue, like we have the electrocardiograms here, so I just keep looking at it. So that's one of the modalities I have to make the ablation safer. Then also this mapping system. Then we have as you can see in the screen, there's a continuous data we have regards to the power, temperature, impedance. So we have this also gives me some more information when I'm ablating. This is going on nonstop, like for like an hour. We have all this continuous feed of the information into our system, and then we have the echocardiogram, which is also this is live image we have of the catheter with the heart. So using all these all this data, we ablate the tissue. Every second we keep getting this data. The data is fed to us, and that's how we respond. So this technique has become very safe and effective, and the technology continues to evolve. And we are anticipating that in the next few months we're going to start some clinical trials to enroll patients with AFib and use some of the newer technologies which we believe is going to make this procedure more safe and effective.
So it seems like the technology has gotten to a point where it's so good that you're able to get immediate feedback on the patient to tell how well you're doing with creating the barrier.
Exactly. And So that has improved efficacy, and above that, it actually made the procedure a lot more safer. So the risk of the procedure has, at least in our lab, is less than 1%. So, and we're gonna keep having the information, and as the technology keep evolving, I think maybe one day will be like less than 0.1% as per the safety outcomes. So this was a study, Cabana trial, which was a very big trial, which was published a couple of years ago, and it showed that the catheter ablation was a lot more effective than the medications. So given all the information which you have received in or from the clinical trials in the last few years, it is very clear to my community, electrophysiologist community, that the ablation is far superior than medications, and we are actually, if we catch Afib early on and treat patients, we could be saving their lives and also decreasing the risk of stroke. And this is incorporated in our guidelines from American Heart Association, that if somebody has Afib, even though ablation is invasive procedure, just because of the effectiveness and the outcomes, it can be considered as a first-line therapy. Now I'll switch gears and go towards the stroke reduction. Now, if we can get patients back into Afib, from sort of Afib back into normal rhythm, we know that they do better. But it's not, we have not come to the level of 100%. We still ranging around, in some early on patients, we can get successes around 80%, but we still have to decrease the risk of stroke. And just to go back to mention that the Afib is one of the most common reasons for stroke. So if in hospital, if we have 100 admissions, so we believe that around 20% of those admissions from stroke, probably from atrial fibrillation. So the mainstay treatment for preventing stroke is to start patients on blood thinner. And if we don't start blood thinners on every patient, we have some risk profiling which we do. If somebody had a history of a stroke, or they are elderly, they have high blood pressure, diabetes, heart failure, they have some blockages in the arteries, and the female gender, in those patients, we believe they have a high risk of stroke, and we start them on blood thinner. The oldest and most, the blood thinner with the most track history is actually Coumadin, Warfarin. It decreases the risk of stroke from 60 to 70%. And if some of you may know that Warfarin, actually, when it was started, it was started as a rat poison. But accidentally, there was actually one of the cattle was accidentally ate a bunch of warfarin and did not die. And that was a time when the scientists started thinking, you know what, we could probably use this in atrial fibrillation and decrease the risk of stroke. So warfarin has a lot of problems, which is the biggest is it's very hard for people to take warfarin knowing that it's a rat poison. And it requires frequent blood draws. You have to come to the office sometimes, every few weeks to check if your blood is not too thin, not too thick. And unfortunately, it also increases the risk of brain bleeds, because your blood is thin, and sometimes your blood could be too thin, and that could increase the risk of brain bleeds. There's a lot of drug interactions, especially with antibiotics, which are very commonly used. And if somebody taking antibiotics, the warfarin may becomes very potent, and somebody could start have bleeding complications. And especially in this town, our patients who are older, there's high risk of fall, and they can hit their head. So those all concerns we physicians had. So because of the problems with warfarin, the next step which happened in medicine was the newer medications, which, like you may have heard on TV commercials, like Pradaxa, Xarelto, Eliquis, Savisa. So all these medications overall are better than warfarin, because the risk of bleeding in the brain is a lot less with these medications. So these are the pharmaceutical, which, like Pradaxa is Devictran, Xarelto, Deroxaban. So all this medication, you can see this line over here. So if medication falls in this line, that means it's better than warfarin. If it's in this line, then it's worse than warfarin. If it's in the middle, then they're no different. So in regards to brain bleeds, all the new medications are far superior than warfarin. So that's why So present guidelines, standard practices, we actually offer these blood thinners, the newer blood thinners like Eliquis, Xarelto, Pradaxa, as a first line over Warfarin, because we know Warfarin is inferior to these newer medications. But some of the problems which we have with Warfarin, which was a bleeding risk, that still stays with these new medications, which especially in elderly, because they can fall, they can have GI bleed, they can have nosebleeds. So the option for those patients who cannot take blood thinners for long term, there is something called a Watchman implantation. So what that is, as I discussed initially, that when somebody's in the AFib, the upper chamber of the heart is not beating, it's quivering, and it has a high risk of forming clots. And most of these clots, they form in this area in the appendage. We call it appendage. So what Watchman is we go in the heart through the groin, and we release this device called a Watchman device. And after a few weeks, this area is sealed over so that no more clots can form in this pouch or this appendage. So it was initially the concept came out actually almost 10 years ago, and the studies have shown that compared to Warfarin, this was the biggest study we had. So it was published in JAMA and Lancet, which again are very reputable journals. That Watchman was better than Warfarin when you look at all-cause mortality. In very vague terms, which means that patients with Watchman died less than patients who were on Warfarin. So then it became an alternative for patients who do not want to take blood thinners, or we think who are higher risk of bleeding. So that was the study which, based on which the FDA approved Watchman. This was, I think, in 2016. So now we still did not know how Watchman was compared to the newer medications like Eliquis and Xarelto. So let me just go to the next slide. So this few weeks ago, again, we had a study called Prague 17 trial, and this is the basic result from the study in which they compared the medication. Mainly it was Eliquis versus the Watchman, and it came out that they were more or less they were same, so they were non-inferior. So if somebody we think are not good candidates for blood thinners, because could be for many reasons, like they had they have aneurysm in the brain, or they have some AV malformations in the stomach, they bleed, they have nosebleeds. In those patients, the Watchman is a reasonable option.
So just sort of to recap, the Watchman is more of a procedure that's done through the groin, like many of the catheterizations, and it really shuts off that pocket where those blood clots
Yes.
form that cause the stroke. So that's an alternative. So
Yes.
that's just so that all of us understand what that procedure is. It's relatively new. I don't know if a lot of the community has heard about the Watchman procedure.
Yes, relatively new. It was approved 4 years ago, and we had not been, at least to my patients, I only offer them if I feel like they cannot take blood thinners for long term, because data we have is evolving. So this trial, which came out a few weeks ago, that's actually increases my confidence that Watchman, compared to the newer medication, is also an alternative. So as more and more experience we get, more and more data keeps coming out, I think it may start becoming like more like a first line therapy possibly.
Great.
And this was the study which I published in JAC, in which because for the Watchman, we still have to keep patients on blood thinner for 6 weeks. And so I looked at the data, and this was mainly from Europe, from Germany and Czech Republic. And there, what they were doing was that instead of putting patients on blood thinner, they were just putting them on aspirin and Plavix, for 6 months. And it was a very similar data, which I showed in the previous slide, that the Watchman patients had a lot less, stroke versus patients who were not on anything. So this is again one of those data is supporting the our practice. So this is a summary. So prevention is better than cure. If we can prevent AFib, that'll be the best. So best way to do is just do all those good things you know about, which is Try to exercise, make sure you eat, you have healthy habits, with dietary habits, so you don't gain weight, limit alcohol consumption. If somebody has sleep apnea, get treatment for sleep apnea. And if somebody has AFib, we want to diagnose them early and to treat them early, so that, as I showed in one of the studies, that does impact the quantity of life and also risk of stroke. There are some technologies coming out, as you may have heard about Apple Watch and the Cardia app. Those are technologies which may help us diagnose asymptomatic patients. But if you have symptoms such as fatigue and weakness, I think it may not be a bad idea to get checked by your primary care physician to just auscultate to make sure your heart rhythm is regular. The blood thinners like the Eliquis, Xarelto, Pradaxa, they do help decrease the risk of stroke. And so they are our first line therapy. But if somebody who cannot take these blood thinners, then Watchman is a reasonable option. And then going back to early diagnosis and treatment, in my practice, somebody is diagnosed early on, I usually offer them catheter ablation as a first line therapy. So that's what I have. So if somebody has any questions.
Oh, great. Thank you so much for that. I really appreciate looking at the actual technology that you're able to use intraoperatively to create that barrier to protect the rest of the heart from that irregular rhythm. So that was really neat to see. And I think it was great to be able to share with the community some of the evolving technology and where the studies are in terms of the treatment and increase awareness for what this Watchman procedure is and how it can help in terms of prevention of stroke. So really appreciate your help there. And thanks for your research to help in more information for us to learn from. So we would be happy to open it up to some questions. It looks like we've received a few, so maybe we can answer some of those.
Yeah, the first question is, what lifestyle habits can decrease the risk of AFib?
Yeah, so in one of the slides I just shown that weight loss is a very important way of decreasing the incidence of AFib. And also if somebody has AFib, and let's say they get ablation or any medication, then just losing weight, keeping your blood pressure under control, and if someone has sleep apnea, getting treatment for it, that makes a significant difference in their outcomes. So yeah, so weight loss, blood pressure control, and just make sure you don't have sleep apnea.
Would you say AFib is hereditary, or is it something someone can gain on their own without having it in their family's medical history?
There is some genetic component, but our lifestyle does make a difference. So we call it lone AFib, which means patient they are not overweight, they don't drink, but still develop AFib. In those patients, the research is going on. We believe there's some genes involved which increase the risk of AFib.
Is AFib something that can go away on its own, or must you have treatment for it?
That's a very good question. And the answer would be it will not go away on its own. If somebody has AFib, let's say when they have one episode, we assume that they're going to have more. So we actually treat them just like anybody who has AFib all the time. So it doesn't matter you have one AFib in 2 years or you had an AFib all the time, they treat it very similar.
And you spoke about a certain procedure during your slideshow. What about the Wolf Mini Maze procedure? Is that something you'd recommend for AFib as well?
So mini maze procedure, actually there are a few ways of doing it. In some centers, the surgeons, let me just give a little brief overview. So ablation is, as I told, the goal is to isolate those veins from the rest of the heart. That's the most effective way. So the most commonly way we do it is we go through the groin into the heart, and we do it very minimally invasive way of doing ablation. So in last few years, our effectiveness has increased, but still there are sometimes, I would say 10-20% of patients we have to go back in to make sure those lesion sets which we created, they're durable. We don't have to do more ablation. So the what Maze procedure is, the one thing is that theoretically, because you go inside the chest and you ablate the tissue with some clamps instead of going through the groin, theoretically you may be isolating the veins more effectively. But obviously, when you go more invasive, your safety is also goes a little lower. So it's risk versus benefit. So far, there's no strong evidence that mini-maze is any better than just a regular catheter ablation. All the trials which came out, they were just single-arm studies in which they did not do randomized study. So there's no strong evidence, and so I don't refer my patients for mini-maze unless I have any strong evidence. And I think in this day and age, we can actually isolate the veins very effectively through the groins. So it hasn't really become a daily practice of referring patients mini-maze.
I've read that AFib attacks are more prevalent at nighttime. Is there any research confirming this? And if so, why is that?
So not in every patient. In some patients, the AFib attacks are more common at night, and sometimes they're more common if they actually start eating. Some patients get AFib as soon as they swallow. And there's a reason behind it. There are some nerves which are connected to the heart, and these nerves, get activated, especially at night when we're sleeping, and more so in patients who have sleep apnea. These nerves get activated, and they can put somebody in AFib. And these same nerve, which activates during sleep, can also be activated during swallowing. So I have very few patients who get AFib episodes when they are eating food, so which is like all the time.
Interesting. I have a question related to the Apple Watch. Have you had a few patients that have come in where it was detected on the watch that they would have otherwise not known, or they were asymptomatic?
Yes, that has happened. Actually, more than few. I would say a lot of patients these days are coming in with their, the recordings from Apple Watch. Actually, my mother-in-law, she has Apple Watch too. She recorded arrhythmia on it as well. I think it's effective. So there was a study done on Apple Watch. So the early generation watches did not really, their accuracy was not there. But I think, and the studies may prove that in future, but I believe that the newer generation watches are providing good quality data, and patients are getting diagnosed early on. So I think they are effective. There's an Apple Watch. There's also called Cardia app, in which there's just an app with you need a little gadget that comes with it, and you just put your thumb on it, and it can read an EKG for you. And FDA just approved another device which can be used for asymptomatic patients to look for AFib. I cannot say as a medical professional that I recommend the Apple Watch or Cardia app because the recent study was not so accurate, but I think that's what the future is.
Interesting.
And it looks like we have time for one more question. Someone wants to know if they have an AFib episode and they're not allowed to, or they can't seek medical attention right away, are there any steps they can do to decrease the episode or just to prepare themselves in order to call a doctor? As in, should they take deep breaths? Should they lay down? Are there any steps to kind of prevent it if they do have an attack and they can't seek medical attention right away?
So I guess to rephrase that question, like at what time you really have to see a physician, like you have to call 911 versus you can just wait and go in next day. So if somebody feels like they have AFib, I assume that they have a diagnosis of AFib. And if they have a diagnosis of AFib and they are taking blood thinners, I think they're safe in the sense the risk of stroke is low. So they should not panic that they can have a stroke if they're taking blood thinners. But if they develop chest pain, or they cannot breathe, or they cannot do any activities because the symptoms are so bad, in those cases, I would recommend they should seek emergent medical attention. But if they are minimally symptomatic, they're just feeling weak and fatigued, but they are on blood thinners, I think they can wait. They can just call their physician, next day, or even depending on the time of day, and they can ask recommendation on the phone. But as I said, chest pain, shortness of breath, feeling dizzy, lightheaded, noticing swelling in your legs, those things need to be addressed urgently.
Well, and I would just add that we've actually seen, and when we did our community series with COVID-19 and heart disease, we've actually seen the incidences that we can record of things like stroke and heart attack going down. And we know that's probably not because they're not happening. We're concerned it's because patients aren't seeking medical care. And so with all of these talks, what we try to do is have the community understand what a great job the medical teams have done here to provide safe, effective care. And that if you do have life-threatening emergencies, to please come to the hospital, because we are finding, this literature is evolving, just as Dr. Sharma said, and we are finding that people are not seeking medical attention for things that normally we definitely should be seeking for. And so please be mindful of that in terms of safety. So I think we're clear on questions. So I just want to thank you again for joining us. This is our second cardiac series, and thank you so much for your time today to help us with all of these things with AFib and the diagnoses.
My pleasure.
We
Thank you for
appreciate
having
it.
me here.
We have one more topic on November 13th, Friday, November 13th. We're going to be talking about congestive heart failure with our expert, Dr. Tassin, and that will be between noon, 12 and 12:45 on Friday, November 13th. We also are planning a general heart health talk to call Healthy Heart during the holidays for early to mid-December, so please look for that as well. So with that, I think we'll wrap up, and thanks so much to everyone for joining us. Have a great day.
Thank you, everybody.
Thank you.